Hi, everybody. My name is Justin Alves, and I am a master's student at UMass Dartmouth in the nursing education track. And today I am going to talk about radical love and how we can use Gene Watson's caring theory to educate students and seasoned nurses about harm reduction and as it relates to substance use disorders. So substance use disorder is a major problem in the United States. Only about 1 in 10 people is actually receiving treatment for their substance use disorder. And we're really defining treatment as traditional withdrawal management, and we are not defining treatment as engaging people in the healthcare system, which is what I would argue we should be doing. Gene Watson's caring theory is an overarching philosophical and sort of set of processes or curative processes to really identify that the nurse has a special transpersonal relationship with the patient that goes beyond the bedside and really helps people regain their wellness and their version of it. And it's all about caring for the individual patient. Harm reduction philosophy is actually very similar in that harm reduction is both philosophical about how we set up a system that cares for our vulnerable people using drugs, but it's also a set of practical strategies about like how can we safely inject heroin. And so when you're trying to design an educational model that really infuses these two things together, it's pretty simple, but you really need to ground it in some philosophical teaching. And one of the things that I always say is at the heart of both of these theories is this concept of radical love, that I am going to take care of and love this patient no matter what. And I think that that is at the heart of what I try to do as an educator as well, which is why this is sort of a fun little project for me. So first you have to identify the audience. And I think the biggest thing in identifying the audience is whether we're talking about experienced or inexperienced nurses, there's a social stigma about substance use disorders that needs to be addressed through the educational model. And that is what I'm trying to do when we're talking about patients in active use. How do we address the social stigma about active use? How do we address the social stigma regarding somebody who's actively injecting heroin in the ICU bed? And what do we do about it? And so we developed this 2-hour-long lecture with an emphasis on cases and discussion, but also that is grounded in philosophy first. And so we really make the case that harm reduction should be something that is in a nurse's wheelhouse. This is directly in line with Watson's caring theory. We are meeting people where they're at, and we are caring for them no matter what their differences might be, and no matter what their health status may be at the time. And then really and truly, what the two big key components of the delivery of the education model that make this sort of unique, that are also infused from Watson's caring theory, are the idea of motivational interviewing and really teaching nurses, either novice nurses or experienced nurses, how do we explore different options with patients and really let patients drive the show about when they're ready to change and what change they're ready to exact. And then the other piece is this expression of positive and negative feelings around the actual experience. And so the positive and negative feelings are guided by the instructor, and then those are addressed in real time. And so as people are having negative feelings about a safe injection site and what that might mean, the instructor is able to really go back to those philosophical underpinnings of the caring theory and harm reduction philosophy and draw them back to the nurse and say, this is why this is okay, and this is why this should be in your wheelhouse. When we had all these frank discussions, what we found is both experienced and novice nurses really got a lot out of this. I was able to do this training both in Hawaii and here in Massachusetts for a variety of different types of nurses and actual other healthcare providers. And largely what we found is what I'm calling an increase in emotional intelligence, right? So it's this decrease in social stigma regarding people who are actively using drugs and an increase in awareness that these are people who are suffering from a chronic illness and need help just like anyone else. When we talk about implications for teaching practice, really and truly, this needs to be a piece of every single nursing curriculum. We know about 25% of all hospitalized patients are suffering from a substance use disorder and are in active use. That does not mean they're seeking abstinence-based treatment. It means they are in active use and they may have some other healthcare problem. And so really teaching nurses, how can we meet the needs of people with these other chronic illnesses? We would never say to someone regarding their patient with diabetes, well, if they're not going to take their insulin, stop checking their blood sugar and just let them do whatever they want. And that's not what we should do with patients in substance use disorder. And, if somebody is not willing to, go to the methadone clinic or go on buprenorphine, is there a way that we can get people to use, clean needles when they're injecting? I think the other piece that sort of I did not speak about at greater length, but really talking about the behaviors associated with substance use and what those might be, and things like sex work, right? And how can we also infuse this harm reduction philosophy and this caring theory around those kinds of things. And I think that that should be in a nurse's wheelhouse, and that should be something that's in the nursing curriculum. But I also think that this is something we should be going back to as a group of healthcare providers, to say our nurses are not adequately prepared to deal with this major public health crises right now, and how can we do that? And I think Watson's caring theory, and really tugging at the fact that every single nurse has this transpersonal relationship with a patient, or with patients, right? And how can we use that as a jumping off point to really get people in the mindset of caring for people in all sorts of different phases of active or inactive use. That is all I have. If you do have questions, feel free to reach out. I'm always happy to answer. I know this was quick, but thank you for your time.